Hi, and welcome to the Conversations About COVID seminar series. I'm Jessie Burke, Associate Dean for Academic Affairs and faculty in the Department of Behavioral and Community Health Sciences. I'm really excited about today's event addressing global health response to COVID. And I'm even more excited about the fact that this was organized and will be run by the students involved with the Global Health Student Association. So it's my pleasure now to turn this over to Bethany Flage, who is a PhD student here at Pitt Public Health and president of the Global Health Student Association. So she's going to moderate today's session and run the rest of it. I am excited to be a participant. So thank you, Bethany, and to our speakers and panelists.
Yeah, thank you. So good afternoon, everyone, and good evening to, I guess, all of our speakers or our panelists. My name, as she said, is Bethany Flage. I'm currently serving as president for the Global Health Student Association here at Pitt. Early in the semester, the executive board of GHSA came to Dr. Burke with the idea of GHSA kind of hijacking the Conversations About COVID series for a week to do something related to global health and global health research. And thankfully, she was very welcoming and helpful with that idea. So thank you to Dr. Burke. One of the things I have been probably most interested in during this time is how and why different countries have responded in the way that they have to the pandemic, and also what those responses have done to students like me and others in academic research. So this is kind of where that idea came from, or where this seminar will center on, and how it came about. So I'll go ahead and introduce our panelists in just a minute. But first, I wanted to take this opportunity to briefly go over GHSA and some of the events we have coming up. So the Global Health Student Association here at Pitt, it functions to promote global health awareness across campus, provide a forum to discuss issues on global health, foster relationships or partnerships with local and international health agencies, and advocate for students to engage in global health research. If you're interested in joining the group or just getting more information, I encourage you to scan the QR code on this slide or the next. And this link will take you to a Google form to submit your email address, and we'll just ask a few other brief questions. So we have some events coming up this month. On October 13th, we will be watching a Global Health Centered TED Talk followed by a brief discussion. And then on October 20th, along with the undergraduate chapter of MSF, we will be having a guest lecture by an emergency medicine physician. So again, if either of those things sound interesting, please scan the QR code and complete the form that follows. We also hope to put on smaller events like this throughout the semester and next. So any input on what you're interested in would be greatly appreciated. So without further ado, we will briefly introduce the panelists we would have with us today. First off is Dr. John Nashega, who is at the University of Pittsburgh, but currently in South Africa, or Capetown, South Africa. Dr. Nashega, I don't believe your video is working, but could you please introduce yourself, where you currently are and what your position is?
Thank you. So my name is John Nashega. I'm an associate professor in epidemiology, and I'm also an adjunct associate professor of epidemiology and international health at Johns Hopkins School of Public Health, but I'm based in Cape Town, South Africa, where I am an adjunct professor of medicine at Stellenbosch University in Cape Town, where most of my research takes place on HIV and tuberculosis. And recently I've been working on several COVID projects. So I'm excited to be part of this panel. Thank you.
Great, thank you. We also have Prof, I should say, Andrew Martin. He's joining us from the University College London in London, England, we got contacted through Dr. Jeremy Martinson. Prof. Martin, can you briefly introduce yourself? Oh, I believe you're muted.
Thank you. I always do that. I'm Andrew Martin. I'm a professor of bioinformatics and computational biology at University College in London. I work largely on effects of mutations on protein structure and function, and the bulk of our research is on antibodies and use of antibodies as drugs. So that's a kind of fairly major area at the moment with COVID research. And I also do work for the WHO in naming and annotating antibody-based drugs.
Very interesting, thank you. We will also have Dr. Solomon of Horiakwa joining us momentarily. He will be joining us from Accra, Ghana. He is a faculty member in the Department of Medicine at the University of Pittsburgh, and then he also currently serves as a Dean of the Health and Allied Health Sciences at the University of Ghana. So again, he should be signing on shortly. And when he does, he can talk about a little bit more of his research. So to start out, we want this seminar, though it's on a webinar platform, to be as interactive as possible. So how this is kind of going to run, or how we would like it to run, is the GHSA board has thought of kind of 5 more basic questions to hopefully start a discussion. Audience members are encouraged to submit questions using the Q&A function of the Zoom, and that relate to each of the topics that we're discussing. And as those come through, I will kind of fill them in to the discussion. So we hope to spend at least 15 minutes on each question. So please don't be shy in submitting any question you have. If any one of the panelists has connectivity issues, as we're still, oh, okay. So I believe Dr. Ofori-Acquah just joined us. Dr. Ofori-Acquah?
Hi, can you hear me?
Yes.
Okay, sorry for the delay. It took a while.
No problem. Hi. Thank you for joining us. So this is, Dr. Solomon of Horiakwa. As I mentioned, he is joining us from Accra, Ghana. Dr. Ofori-Acquah, can you briefly state your name and your area of research?
Sure. Name is Solomon of Horiakwa. I am a faculty at Pittsburgh. I also have a joint appointment in the University of Ghana. The primary area of research is sickle cell disease.
Thank you. So as I was saying, if any of our panelists has connectivity issues, feel free to turn off your camera. And as this may inevitably happen, we just ask everyone to be just a little patient with us. So I will unshare my screen so we can kind of more easily interact. And just to kind of start us out and to get an idea of where everyone is at, in the US, we have been hearing about the pandemic responses of different countries, how they've been successful and or not so successful. So briefly, I just want to go around and have each of you talk about what your respective country did when the pandemic hit on a scale of like total lockdown to no restrictions. Where exactly did it fall? Dr. Ofori-Acquah, do you want to start us out?
Sure. Let me go first, just in case we have connectivity issues down the line. So I'm talking to you from Accra, Ghana. Accra is the capital of Ghana, which is in West Africa, for those of you who are not familiar. The pandemic, in fact, I was actually in the US in the 2nd of March, early part of March. I was in the US in Washington, St. Louis for a seminar, but I was due back in Ghana the following week. So I think I was in the US when the first US case was announced. Ghana had a 0 at the time. So it's quite an interesting story. I was concerned even at that early stage that I might not be able to get out of New York. So I flew out of New York on the 5th of March, got to Ghana on the 6th. The really pandemic news had not even hit Ghana. But within a week, a few folks had returned to Ghana from Europe, I think initially Europe, who were testing positive. And so the screening for COVID in Ghana takes place on the research center in the University of Ghana. So those of us who are faculty here were sort of intimately aware of what was going on, even if the general public was not. And so fast forward just a week after I came back, March 15, 16, thereabouts, we're beginning to see 2 or 3 cases. But then by another week or 2, the number had gone up. And so the authorities in Ghana did a pretty good job in instituting screening at the airport. We have one major international airport, so that makes it a little easier. So folks from select countries, US, Europe, were being quarantined in nearby hotels and then tested. And if they were negative, they obviously were released. If they were positive, they were kept in those hotels near the airports for a couple of weeks before they were released. The numbers kept, going up steadily, and the Ghana Health Service basically had on their website, sort of updates so you could follow the number of cases, and were really not large numbers, 20, 30, 40. I think it took probably about a couple of months before there was 1 death. But as the situation deteriorated, the country had a partial lockdown. And so the 2 big cities were essentially locked down, Accra and Kumasi, for probably about a month. And then looking at the incidence of the infection, the government relaxed the lockdown. The universities were closed. So I'm in the University of Ghana, which is one of several public universities. All the universities were closed. Students were basically sent home. And then as the semester wore on, all of us had to transition to virtual, virtual teaching. And then exams had also been done virtually. For some students, medical students, where complete virtual examination is not possible. In the last couple of months, the government has relaxed the shutdown for students, and so students final year students only have been able to return to finish their exams. And so right now where we are, some of the other shutdown activities, churches, large gatherings, were all stopped. Funerals are a big thing here. They were all stopped, but they have now all been relaxed, and these things are now going on. Mask wearing is a must. So I have my mask here. You can't go anywhere without a mask. This is the Ghana flag. People are making money out of this, which is okay. But the masks have to be FDA approved. Actually, people are selling them that are not FDA approved, but this particular one is FDA approved. So right now where we are in Ghana, again, because I'm in the university and we get to see really the coordination of the response is based in the University of Ghana. We have a tertiary hospital in the University of Ghana Medical Center, where now for the last month, all the severe cases are being handled. And I just happen to know that as of last week, in the whole country, there were a total of 2 patients who were on a ventilator. One of them actually passed 3 or 4 days ago. So as I speak with you, to the best of my knowledge, there's only 1 patient who is on a ventilator related to COVID-19 in Ghana. A lot of people are going around as if the virus is gone. And so as if you were to ask me what is the current state of affairs in Ghana, I would say everybody's wearing a mask and maintaining social distancing, but life is pretty much back to what it was before COVID. And I just heard today, Delta has resumed the flight from New York to Accra. And so I think we are back to where things were before COVID, with the only exception that we all go around wearing masks and keeping distance as best as we can.
Thank you. I kind of assume it might have been similar in South Africa. So Dr. Nashega, can you speak a little bit about what happened at the beginning and what's happening now?
Oh, yeah, sure. Can you hear me?
Yes.
Yes, okay. Hi again, everyone. The first case was confirmed of COVID in South Africa was a traveler who had returned from Italy and was diagnosed actually on March 5th, when about 400 cases has been identified. After 18 days, the government announced a national lockdown, which was implemented 4 days later when the doubling time was about 2 days. And there were about 1,000 identified cases. During the 35 days of strict lockdown, the doubling time slowed to 15 days, which was a good thing. And there were about 5,000 cases by April, end of April. But in mid-May, when a less strict lockdown was in place, South Africa has recorded about 17,000 cases and about 300 deaths. So South Africa actually response has included overlapping stages. The first stage was focused on preparing COVID-19, including establishing testing. Stage 2 was started when there were about 50 cases 10 days after first South African patient was diagnosed. The government declared a national state of disaster, banning international flights, closing school, restricting gathering, and promoting social distance and hand hygiene. A high-level advisory committee, which included clinicians, virologists, epidemiologists, mathematical modeler, public health practitioner, and other experts, provided really strategic advice to the Minister of Health, establishing an evidence-based policy guidance. In a stage, what they call a stage 3, there was consisted the national lockdown, which now has been was eased slowly. The lockdown has caused the problem. The lockdown has caused a substantial economic hardship during that stage 3. The contraction of economy really had important long consequences. Restriction on movement and contracting COVID in healthcare facility has brought major reduction in comprising access to TB and HIV management of cases. But during a stage 4, which was initiated about on day 30 by the government, they deploy about 1,000, roughly 30,000 community health workers to the high-risk community to undertake active house-to-house case finding. South Africa is community contracting team established, which was modeled to TB control, was used for contact tracing and monitoring of compliance of quarantine. With the highest HIV burden in the world, South Africa has that really impressive network of provider and community health worker, which could been able really to rely on for a door-to-door community testing and contact tracing and checking for people are complying with the quarantine. Stage 5 involve identification of hotspots, which some cluster epidemic, which allow also to bring the epidemic under control. So as of today, as I'm talking now, so South Africa, which has the highest number of COVID on the African continent, they've been able, cumulative accumulated cases was about 670,000 confirmed cases. There were about 16,000 deaths, but there were 600,000 about people who recovered. And again, just to tell you, we passed the peak. We are now in the South Hemisphere. We just also at the end of our winter. So at the peak, there were the peak was about on daily basis about 13,000 cases. But now, as as of yesterday, they were recording only about 900 cases. So we are down the line, and all the lockdown restriction has been eased. We now allowed to go out. Everyone is complying. The majority of people here are complying with the mask wearing. There is also, as in Ghana, in South Africa yesterday, the first flight, they open international flight. The first flight coming from Dubai landed in Capetown yesterday, and one from Netherlands in Johannesburg. So we're getting slowly back to not a neo normal, but a new normal, I would say. So that just in overall, there was some expectation that Africa going to be hardly hit by this epidemic. So we can discuss later why the epidemic did not really hit as bad as it was earlier expected. So so I'm gonna stop there just to that's the South African situation. Thank you.
Thank you. And Prof. Martin, can you kind of talk about what happened in the UK and what's happening now?
Sure. So, yeah, I hate to say that the situation in the UK was a complete mess, but it kind of was. I mean, obviously, nobody really knew what the right strategy was going to be, so maybe that's a little unfair, but I guess we were the third or fourth in Europe to have a significant outbreak of COVID after kind of Italy and Spain, and around about the same sort of time as France, I guess. So I think we were told very vaguely to start being careful around the beginning of March. And at that stage, restaurants were still open. There was no requirement to wear masks, no really strict instructions, just a sort of vague instruction of stay at home if you can. But at the same time, things like restaurants were open and clearly suffering hugely from not having many customers coming in. So I guess it was second half of March when the proper lockdown was introduced. So that was really a full lockdown, other than going to some essential shops. So most shops were closed down, but obviously food and chemists and some other things were open. But they had to implement strict distancing of 2 meters. Most shops introduced kind of one-way systems through the shops, but still no masks required at this stage. So that seemed to have a reasonable effect, because basically all non-essential businesses were shut down. There was a very good furlough scheme introduced by the government, so that protected an awful lot of jobs. And really we stayed in complete lockdown with all pubs, restaurants, non-essential businesses basically shut down from second half of March until early July. So I think it was around about the 4th, 5th of July or something that things started to open up again. So I think we've had a total of about 460,000 cases and a total of about 42,000 deaths. Now, I did see something in the Q&A asking about this, which is the way that things have been measured are very non-rigorous, if you like. So originally all the cases that were being measured and recorded were only cases in hospitals. There was no testing of anybody unless they were ill enough to be in hospital. So consequently, early on, the percentage of people dying was pretty high. The first wave of cases was very much over at the time that the sort of easing of the lockdown. During that easing, there was actually a big escalation in testing. So now, at least in principle, you can get a test if you have symptoms. In some cases, though, I mean, we have a testing centre about 10 minutes drive from us, but if you go online and try and book a test, you're told you have to drive about 200 miles to get to a test centre. So the situation in testing is really quite poor still, but it is gradually improving, and certainly there are lots of tests being done now. So we are very much into a second wave at the moment. So after all that easing of lockdown, the restrictions were kind of eased on a gradual basis, and there was a phase during which we could then start going to more shops were opening, restaurants were opening, and pubs were opening, but with a requirement for shops that you wore masks, but then reducing the kind of requirements for one-way systems and dropping the social distancing from 2 meters to 1 meter. But then things like pubs and restaurants, obviously you can't really wear a mask while you're eating or having a drink. So those were kind of exempt from wearing masks. And now with the second wave coming, we've now changed to requiring masks in things like pubs and restaurants, unless you're sitting at your table. All bars and pubs require you to sit at a table and have table service, so no kind of standing at the bar. The effects of that, we've also changed some regulations around numbers of people in groups that can meet up. So we did have a regulation that it was up to 6 people inside if they were from 2 households, and up to 6 people outside from any number of households, or up to 30 if they were only from 2 households. So rather kind of complicated rules, which were kind of misinterpreted by a lot of people, and that led to a lot of groups particularly of younger people, I guess, meeting up in groups of 30 and really not maintaining social distancing, which we're supposed to be doing. So now that has been changed to a simple rule of 6, whereby it can be from any number of households, inside or outside, but only up to 6 people in a group. Now, that together with now a requirement for wearing masks unless you're sitting at your table in things like bars and restaurants, does seem to be slowing the second wave. It's been estimated that the R number has gone down from about 1.8 to 1.1, 1.2. So that does seem to be having some effect. But we're also now having local lockdowns in various cities and areas of the country, which are back down to essentially full lockdown, although schools and things are now open in those places. My wife's a teacher, and obviously they went back to school 2-3 weeks ago, something like that. They have now got 3 confirmed positive cases amongst their pupils. The year 10, which is what, 14-year-old, only about 20% of those pupils are now in school, because they're kind of in like bubbles, whereby if one person tests positive, then the whole bubble has to self-isolate. So, you know, I think we haven't done too badly. On our total number of deaths and cases has been pretty high, but when you correct for the population, there are certainly other countries in Europe that have done a lot worse. Neil Ferguson, who's an epidemiologist at Imperial College, estimated at the start of the pandemic that we would be expected, with no measures taken, to have about 400,000 deaths, and with the measures taken, we've so far had about 42,000. So on that basis, we seem to be doing reasonably well, but I think we could have done a lot better by introducing a lockdown earlier and requiring masks from much earlier on.
Thank you. So we have a few questions in the chat that I kind of just want to touch on. One you kind of mentioned a little bit early. So as far as like differences on how each country defines records and compares COVID deaths between COVID deaths and then deaths as a result of a comorbidity, can any of the panelists speak to how these statistics are different or could be different?
So I'm not sure I can say how they're different, but I can say a little bit more about what we've done, which, as I said before, it's a moving target. So initially we were just counting cases in hospitals, and deaths were recorded with COVID. So in principle, at least, somebody could die in a car accident, and if they tested positive for COVID, that would have been recorded as a positive case of a death. We do have also numbers of the number of deaths in excess of what's expected at this time of year, and that has been, I think, about 60,000 compared with the 42,000 deaths recorded from COVID, or with COVID, as we tend to record. But obviously that reflects things which may have been worsened by the presence of COVID. So, for example, we've had a big problem with people not getting cancer treatment because of COVID. The amount of testing and the reports of cases obviously has gone up hugely, but for us, the percentage of tests proving positive is also going up. It's been a moving target for us. You know, the way things are measured has changed throughout. So I don't know what other countries have been doing.
So for Ghana, and my internet has been going in and out, so I hope you can hear me. Can you hear me? Mm-hmm. Right. So Ghana, the country has sort of had a very good handle on the cases, really because the test sites were not that many, right? There was really one major test site, and then over time, a few other test sites were added. And so it makes the getting a handle on the positive cases and the well-being of those individuals easy to track. There is a coordinator who coordinates essentially what is going on. So if somebody tests positive, and I know somebody who tested positive, that they have to call every day. And if they tested positive and are not sick, sufficiently sick to be hospitalized, they have to call every day and give, you're asked to buy an SpO2 and give your oxygen saturation and your temperature. And that is basically recorded. And then as I said, the number of hospitals that care for COVID cases are very few specific ones. And so just to give you some numbers, based on positive cases alone, so far, confirmed cases in Ghana is 46,656. 45,000 people have gotten the infection and recovered with no symptoms. There have been 301 deaths. As of now, there are 30 new cases. So this would have been cases happening in the last last few days. And the number of active cases is 413. So as I said, because of the number, the test sites are not that many. And so anyone who tests positive is required to call in every day. The health service, the Ghana Health Service, is able to keep a track on the cases. The gender distribution is interesting. There'll be more males, about 58% of males compared to 42% of females who have tested positive. And so the way the cases are counted is really about cases and not the number of tests, which I think from what we heard a while back, I think may have been some of the issues in the UK where tests were being counted rather than individuals who were being tested. So that's the situation from Ghana.
So if I can just come back on that, we're not counting the number of tests, it's just the number of positive cases is going up as the number of tests are going up. So, you know, that's obviously going to happen, particularly with the, you know, the number of people who do seem to be largely asymptomatic. If you start testing more people, you're going to find more positive cases. So that's been our problem in comparing the number of positive tests with more testing compared with positive tests with less testing.
Okay, thank you for that clarification.
So moving on just slightly, in regards to the pandemic, can you all speak of any specific challenges your country has had to face that might be unique to your country? Dr. Ofori-Acquah, you just mentioned that the health or that positive patients were supposed to call into the health service. Was compliance on that very good? Did we lose you? Okay, Dr. Nashega, can you speak about any specific challenges that South Africa has had to face? These could be anything from social and behavioral factors, public responses, infrastructure challenges.
Sure. Can you hear me?
Yes.
Yes, I think one of the main challenges at the beginning of the response was related to the lockdown. As you know, majority of a substantial proportion of population, living at really in high poverty. So the lockdown, cutting a number of jobs, informal jobs did have a huge impact on the socio-economic situation of the population. So that was a really hardship moment for majority of people. Despite that, the government did provide some assistance on really people who really live under below the line of poverty. So with easing the lockdown and allowing people to go back to do some work, and since majority of South African population has been complying with public health measuring, mask, social distancing, in the townships, despite that poverty condition, lack of sanitizer, lack of overcrowding. Those challenges over time were somewhat managed with the help of the government. The other challenges was actually at the peak of the epidemic in South Africa, which was about June, July. So there was a huge number as people moving from testing in health facility. So there was a rollout of testing in the community, as I mentioned, with community health worker model on HIV TB response went in community. So the number of testing increased massively, which was a good thing. But at the same time, laboratory were overwhelmed, so we experienced in South Africa by the delay between the testing and the result ended up to be on average a week, sometimes 10 days, which was not really optimal in terms of contact tracing and isolation. So that's the second challenge, the delay to receive, the response, the test result. Another challenges I think one need to mention was HIV and TB control. People on those conditions, there was also impact on accessing chronic TB and HIV facilities, since HIV and TB are the major chronic infectious disease in this context. So those were also challenges. Interruption of chronic services for tuberculosis were other major challenges here in South Africa. And actually, one of the recent paper showed that HIV may have, people with HIV may be more likely to acquire COVID, as we show for other NCD. So that also, the impact on HIV and TB is something that is evolving, not only in terms of the risk, but also on impact of providing a provision of services. So I will just mention those three challenges, but happy to debate more.
Thank you. I know one thing we've kind of had to deal with more so in the US is, I mean, we're in the middle of an election year, so there's been a lot of kind of political pressure and a lot of conspiracy theories that have kind of cropped up. Has any of that reached Ghana, South Africa?
so from South Africa perspective, I have to say that people been really applauded the government response in terms of strict lockdown and also travel bans. But at the same time, as there is the lockdown, it was really remarkable to see that the majority of people are complying with the mask wearing. And despite that, social media is quite very active, popular here in South Africa. We are not experiencing, situation currently happening in the US in terms of, those kind of controversy in terms of, public health measures. So that in South Africa, people have been quite well complying, which allow today really to see coming back on the epidemic curve, and the people now are preparing to the summer, and we still don't know in the summer, but we don't expect really to go back to the situation we were in a couple of months ago.
Yeah, there hasn't. So with respect to the political angle, I think the government here in Ghana has really had high marks in how the COVID was handled, to the extent that I think this was even a write-up in international newspapers about how Ghana handled, and I think that was really because the instituting, testing, or rather quarantine travelers at the airport very early, and the borders were closed. I think that's really helped. But of course, the numbers in Ghana are not that high, and so in addition, the president, I haven't watched any of these, but I think he's been giving weekly, well, every now and again, he gives an update, a full address on this. I think he does it every 2 weeks or something like that. So there has been transparency in sharing of the data. The data is easily available. The Ghana Health Service website, we actually have a link to that on our center website here. So you can, every day you can go and see what the situation is. The mask wearing, the fascinators have taken it on and making different types of masks with Ghanaian garments and so on and so forth. So it's become almost a fashion accessory for some people. But then there are large swaths of the population, like in the markets and stuff, where people don't wear the mask. I was at a funeral recently, and a lot of people were wearing masks, but others were not. And it hasn't really had any, because the numbers have steadily gone down, the government's handling of it, even if it was not the best, the numbers have been there to support their claim that they did a good job, right? And so there hasn't, it's really, and Ghana, we are also in an election season. The Ghana calendar runs similar to the US calendar. Our election is in December, and the opposition really cannot make a big deal out of COVID because the numbers are really not there to make a case out of that.
I believe, from what I've heard, the Ghana president is pretty well respected in the nation.
Yes. I mean, he really, and it helps that he obviously listens to the scientists, the virologists, and I do. This is just personal information, but I do know, the top molecular virologist in the country also happens to be his cousin. So I'm sure he gets a daily briefing on what the situation really is without any sort of political filter.
That's great. So Prof. Martin, can you speak to, I think when we spoke earlier, you kind of mentioned that the conspiracy theories reach London at least. Can you speak a little bit about that?
Yeah, I mean, So in terms of also actually just to answer one of the questions on the Q&A related to what the UK does. Yes, we have a primary care system with doctors' offices known as general practitioners or GPs, but they don't do any testing. Basically, largely they are doing face-to-face consultations now, but they try and make it as difficult as possible for you. They prefer to do consultations over Skype or Zoom or whatever, or over the phone, unless you really need to go in. So we have testing centres, and there are a lot of them around. But you can also get home testing kits delivered. So in terms of the other problems that are going on, yes, we suffer a lot from the conspiracy theorists, that it's a scamdemic, and lots of people refusing to wear masks. I mean, to be fair, when normally you go to the shops or wherever, the vast majority of people are wearing masks, but there's certainly a vocal set of protesters who refuse to wear masks. They seem to claim that it reduces your oxygen levels, despite the fact that that's complete nonsense. They actually had a big rally last weekend in London, of literally thousands of people protesting and not wearing masks, and actually it got stopped by the police because they weren't following the new social distancing rules that have become a bit harsher now. So that's a problem, and it remains a problem, partly because of the rather loose law that we have around mask wearing, because the law says that we have to wear masks in shops, restaurants, pubs now, and so on, but you don't have to wear a mask if you have some sort of illness that might make it difficult for you to wear a mask. I suspect most of those illnesses are related to breathing, in which case if you do get COVID, you're probably going to die. So I would have thought that was a good reason to wear a mask. But also it has some clause about not having to wear a mask if wearing a mask would give you anxiety. So of course all these refuseniks basically just say, yeah, I get really anxious about wearing a mask, so I can't wear one, and the police can't do anything about it. Of course, it's perfectly within the rights of individual shops, pubs, bars, restaurants, and so on, to just say, no, you're not allowed to come in without a mask. They can deny or allow access to whoever they like. But yes, the kind of QAnon-driven conspiracy theorists are quite scarily active in the UK, and I think that is certainly a problem here. I mean, I have made quite conscious efforts to try to negate everything that they say on kind of public fora on Facebook and so on, but really you just get nowhere with them, and I don't expect to be able to change their minds, because it's almost like a kind of cult religion to them, but I do hope to influence anybody who is kind of wavering and thinking that this may be true, what they're saying, by just basically showing the science that proves most of what they say is complete nonsense. So I think there's also a little bit of a problem in the UK that, so so we do have a bit of a drinking culture. And one of the recent restrictions that's been put in is a curfew on all bars, pubs, restaurants of 10 o'clock, with the idea that it would stop people staying in pubs, getting drunk, and then sort of forgetting about their social distancing and so on. However, in practice, that's meant they chuck loads of people out onto the street all at 10 o'clock, who then descend on local off licenses, as we call them, liquor stores, or to supermarkets in order to buy alcohol and then sort of get drunk in the street. So that there've been loads of film on television over the weekend when they first introduced this, of just crowds and crowds of people. So it doesn't seem a terribly good solution.
Yeah, that's a problem here as well. I know we had, at least in Pennsylvania, we had a rule that said if you were dining at a restaurant, or you could only get a drink at a restaurant if you were dining. So you can't just go to a bar and drink. And I believe like the actual bars are closed still. So you can't, you have to order from a table. So there's a lot of similarities there. One question that I want to make sure we get to is more specific for students, and Dr. Martinson just mentioned something in the chat as well, where talking about the challenges you've seen for your students. Dr. Martinson mentioned that one of the biggest challenges was ensuring that master's and doctoral students who were due to graduate were able to do so. So how did the University College London, and I think Dr. Ofori-Acquah can speak a little bit to this, or a little bit about this for the University of Ghana as well. How did the universities deal with this?
Yeah, so actually we've had quite a good kind of response and solution in the UK, not UCL as such, but universities across the UK. For master's students on kind of one-year programs, largely the expectations and requirements for writing a master's dissertation were changed. So for example, one master's course where I've had a student, they changed the requirement from the normal amount of kind of lab work to basically having some basic lab work that they'd done before the lockdown, and then using that as the basis for writing a grant application rather than writing a full dissertation. So I think in the main, master's students have been okay and managed to complete on time. PhD students, on the other hand, particularly those in wet labs doing experimental work, have had a huge problem, because obviously the labs were all basically completely closed for 3 months. So they, while at the moment, obviously this has largely affected final year PhD students. So our PhD programs tend to be either 3 years long or 4 years long. So either third or fourth year students. And they obviously could start doing some writing of their thesis. So that might be, you know, a month or two of that time used in a valuable way. But actually the research councils, who are the government funding agencies that fund the majority of PhDs in the UK, have all given 3-month or in some case 6-month extensions to PhDs. So there has been extra funding from these government organizations to cover that. So they haven't finished on time, but they have had more money to be able to carry on. Now, some of the charities who fund research, they've all been a bit different in how they've done it. The Wellcome Trust, who are one of the biggest kind of medical funding charities, gave all final year PhD students a 6-month extension. No questions asked. The research councils, you had to write a brief case to explain why you needed an extension. In the case of Wellcome Trust, they've just given everybody an extension. So in fact, a final year PhD student of mine who is doing a purely computational project didn't really affect him significantly because he was able to carry on doing his work perfectly well from home, but he's got a 6-month extension, so he can do a little bit more work. So other charities have not given extensions, and I don't know, and of course this also applies to self-funded students. They obviously can't give themselves an extension unless they can afford it, but at least at UCL, for those people, there has been a pot of money to give them an extension of an extra 3 months. And also in the case of at least self-funded students, there has been the option to take a 2 or 3 month suspension of studies retrospectively, so that basically for those 2 or 3 months they don't have to pay fees. That doesn't sort out their living costs, but at least it removes the fees element. So to answer Jeremy's question, master students, I think we have in general managed to get all those through. PhD students, basically they've all been given extra time.
Dr. Ofori-Acquah, can you speak to how, go ahead, Dr. Nashega.
Yeah, so in Ghana, the leading universities in Ghana are public universities, and so the way the students have been impacted here has really been directives that have come from central government. And as I said, the public universities were closed. And so the immediate concern for students, and this happened when we were probably 40% into the semester, right? The semester runs from January to May, June, and then this hits basically in August. So let's say 50%. So because the students were asked to go home, and then not long afterwards, the University of Ghana and the other universities sort of migrated all teaching to online. The issue then became a financial one, where students now had to sort of buy units or credit, as we call them here, to be able to access the teaching material online. So the University of Ghana and other universities did provide some sort of credit for data for students. The challenge in Ghana and really elsewhere in Africa is really one of infrastructure. And so the communications system are pretty good. Actually, Ghana has one of the best mobile money facilities in Africa, essentially in the world, which is now good for folks who want to send money to their relatives. But that's usually a single transaction, right? You just go and you do it, and so that works very well. But to log on onto your computer for 40 minutes to listen to a lesson live is challenging. And so what a lot of us did was to provide recordings of our lectures, so that when students are having connectivity problems, the time of the lesson, they can always log in later on and basically listen to the recording. And so that was really the major challenge for students in terms of cost associated with buying data to access virtual classroom activity. That really was the main one. As I said, final year students were given the option, and those who had challenges with connectivity were added to that group of final year students who were then asked to return to the university for a couple of weeks to do the exam. So students who could not access teaching material because they lived in two remote areas that were too remote. These connectivity challenges are a problem everywhere, but more so in places away from the capital city. So those students had the option to come back to campus. We've completed the semester. We've done all the exams online, and graduation has already started for some disciplines online. And so we're all now getting used to it, and we're going to reopen for the coming semester in the next few weeks, and teaching will be basically mixed approach. For courses that are happy to continue online, it will be online. And for courses that need to have face-to-face, they will arrange to have face-to-face, obviously maintaining social distancing. So overall, I mean, some students, okay, so in terms of students' frustration, some students have not been too happy during the virtual graduation, right? Because graduation is a big day for students. And so some of the student representatives were really pushing for the University of Ghana to do this. And that was really not held by another major university here that actually did in-person graduation. And that sort of became ammunition for other students to say, well, why can't we have that as well? But at the University of Ghana, we decided against that because even if we did do that in the graduation hall, all the rules about social distancing will be adhered to. But as soon as students get out of graduation hall and on the university campuses and doing their partying and stuff, we felt that the social distancing rules really will be adhered to. So the university made a decision to go with totally virtual graduation. But that was one of the major things that students were against, that they wanted to have in-person graduation. Thank you.
Thank you. So Dr. Nashega, you talked a little bit about how HIV and TB are really big factors in your COVID patients. So I'm just wondering what kind of impact do you see on the future of, or future challenges for those patients? So both short and long term, do you see like more of a resurgence of these diseases? And maybe not only HIV and TB, but others as well?
Thank you very much. So just to go back on the specifics, so data are just emerging, and we still need to do some more research to understand better the epidemiology of the concurrent COVID and HIV. But one of the major study, it's a population-based study, which has been published in Clinical Infectious Diseases. It is among about 3 million patients, 16% were HIV positive, 22,000 were diagnosed with COVID, of whom about 600 died. So COVID death was associated with male sex, increased age, diabetes, hypertension, and chronic kidney diseases. So HIV was associated with COVID mortality, and that was really, when you look at adjusted hazard ratio of about 2, which was really statistical significant, which was even similar risk across strata of viral load and immunosuppression. So this was a major study, even if this is observational population level data, which can still be confounded, but unmeasured factor. But this is really the only study which need to be confirmed by other cohorts, not only in South Africa but in other African countries. So we currently trying to look at several factors which beyond HIV and tuberculosis and or malaria or other kind of chronic condition that how they are impacted or they impact COVID. So this is with some funding from Fogarty, we're planning to compile data from patients of COVID across 5 countries: South Africa, Ghana, Nigeria, DRC Congo, and Kenya. So this is a project that will take off soon. So we will look at, we'll try to see how, prevalent condition, how they impact COVID and vice versa. So this is something, and this study will not only focus on adults, but we look also on some key population like children and adolescents, and also a separate study looking at pregnant women. Going back to children and adolescents, we can also, we're planning also to look at some specific condition like Solomon mentioned sickle cell anemia. So this is our condition. Also, we still don't know how they've been impacted by COVID. So there is a really a range of specific condition in Africa, which it will be really interesting to look as we progress, because it's going to take probably some time before we fully control COVID. And as I say, one of the major impact that we try to minimize is that people who are HIV on antiretroviral treatment and who are virologically suppressed, to make sure they maintain their viral suppression in terms of adherence and access to care where they need to get to care. And one of the options we're trying to make sure that happen is to try to differentiate it, access to the antiretroviral, so we can have home refill of their medicine. We can have also mobile team which go in the community, so we can provide them evaluation of their status and their virological testing close to their home, because so they don't need to travel, they don't need to go to health facility. So those kind of community-based model of HIV, but also TB, tuberculosis care in the era of COVID are even becoming very critical. And they've been already pushed a couple of years ago by WHO and most of control, HIV, TB control, but they're becoming even more important and really making a difference in the era of COVID. So those are the key issue of differentiated model of care for chronic condition, infectious disease condition. But what about one of the key, I think, as we're learning that non-comorbidity like diabetes, hypertension are really risk factor for severity of COVID. So this is also, we try to see if what data coming from US, Europe, mirror data that we are seeing here. So some preliminary data we have a concurrent COVID and hypertension of about between 25% prevalence to 30% prevalence. So and that for hypertension and diabetes. obesity is a bit less compared to what is being reported in the US or in Europe. But again, we are looking at this quite closely. So we will be reporting some data before Christmas about this on also a separate study which gonna be multinational across several African countries.
It's very interesting. And what about the future of like hybrid-based learning for students in South Africa and Ghana? Do you think that's going to play a bigger role?
I think so. So just commenting, compared to Ghana, we did not really have an hybrid. South Africa has a very somewhat sophisticated and developed distance learning program that they did put really at use during COVID. So there have been no face-to-face classes until now. And as we're moving, the program in South Africa at tertiary level, it's in a month or so, we're gonna, close. It's gonna be the holiday, big holiday, kind of June, July, August, compared to the US. So we don't think there are gonna be any face-to-face classes until next year when the new year starts. But that say, as I say, all were really distance learning through from home. I have to admit that while that may be true in big city like Cape Town, Johannesburg, or Durban, in remote provinces, there have been some report of not only at tertiary level but at high school level of challenges for students accessing continuation of instruction of education at home because of lack of laptop, lack of data. But as far as data is concerned, all the education has been zero rated, so both at tertiary level, but at high school level. So that is not a problem in South Africa. So the government make it really free. The main challenges were that, underserved and underserved students could not access, don't have a laptop. And so that was some challenges in most of remote provinces in terms of having the proper material to be able to learn from home.
Thank you. So we've got about 8 minutes left. So Prof. Martin and Dr. Ofori-Acquah, can you just spend a couple minutes talking about the future for things like hybrid learning for your students?
Yeah, so that's certainly something we've been doing. The lockdown in March didn't have a huge effect because, at least at UCL, because we don't really do any teaching after the Easter holiday. It's all examinations then, so all the examinations were moved online. This term, so our students basically came back last weekend, and from then, this is undergraduate students, from then up until Christmas, we are doing all of our lectures and all of our tutorials are online, but we are doing some face-to-face sessions of things that are not going to be examined. So there will be some practicals running, there will be some sort of first year things on finding out about your tutor, learning how to read a research paper, that sort of thing, which won't be examined directly, but that gives them some face-to-face teaching. So I think of the what we call the Russell Group universities in the UK, which are sort of the top 20 or 30 ranked universities, we are actually doing the least face-to-face teaching of anyone. but I think given the situation at Manchester University in the north of England, which is also Russell Group, and I think their students went back 2 weeks ago, they now have over 200 positive test students at Manchester University. So essentially lots of the university has been having to lock down anyway. So our students have come back to London, or at least a lot of them have. But I think probably about a third have actually decided to stay at home and just do the online classes, lectures and tutorials rather than coming in. So we are trying to accommodate everybody, really.
And Dr. Ofori-Acquah, what about the future of hybrid learning for students in Ghana or at the University of Ghana?
Say it again, Bethany.
Do you see a future for hybrid learning at the University of Ghana? Do you see something like this taking off there? I mean, I think there are a lot of like hybrid, so online and in-person learning.
Oh, hybrid. Yeah. Yes. So that was ongoing anyway.
Okay.
So the university has a distant learning program. We have several degree programs that are for students who don't come to the university. And so for those students, a lot of the university has a few sort of online platforms, Sakai platform that was being used for that. And then of course, COVID made that more widespread across multiple programs. And so now, essentially, we've gone through a semester where virtually all exams were online. And now we're going to, the next semester is a hybrid model, where for some programs, especially for the humanities, where they don't have to have, wet bench sort of practicum. So I think this was ongoing at a low grade, and now I think it's going to be the norm, not just for the University of Ghana, but other institutions in the country. I know, for instance, the professional banking institutions where folks are learning to become bankers and they do exams. All of that had to be migrated to online, and I think it's going to stay there.
Thank you. So I think we'll just kind of wrap it up. I just want to thank all of our panelists for joining us this afternoon. I know it's starting to get late, I think everywhere that you are. So I really appreciate you signing on and taking the time to join us this afternoon here, evening for you. Hopefully, maybe we can do this again sometime, but we'll see. So yeah, and with that, I'll turn it back over to Dr. Burke to talk about next week's seminar.
Wonderful. So thank you so much. I really love that we had speakers join from around the globe, and the technology that allowed us to connect and learn from each other and to learn more about our shared experiences. It seems like we all have many common experiences, maybe slightly different in the specific context, but it was great to learn from you all. So I want to say a big thank you to GHSA for organizing this, and to the panelists for putting on this fantastic seminar. And thank you all for participating in today's conversations about COVID. I hope that you'll join us again next week. So we will return to our regular 4 o'clock time on Fridays. Dr. Mary Hawk, who is faculty here in our Behavioral and Community Health Sciences Department, will be joined by Julia Marcus, who is at Harvard Medical School. She's had a number of articles appear recently in The Atlantic about COVID, and specifically about the harm reduction approach to COVID. So Dr. Marcus will describe how the principles of harm reduction can be applied to public health messaging. And Dr. Hawk will talk about some work that we've done and the application of the compassionate framework within the public health higher educational system. So this idea of how can we use the harm reduction approach. They'll talk about things like balancing uncertainty, concerns about what's best for population and personal health, the tensions between collectivism and individualism. I'm sure it will be a great conversation, much like today's was. So I just want to thank you all so much again and say have a great afternoon, evening, wherever you are. Thank you so much.